Good morning. Welcome back to 1160 AM KBDT News Talk Sports, where JP, Kathy, and the crew, we come to you live Monday through Friday from 7 a.m. to 9 a.m. It is with great pleasure today that we have the mental health moment that'll be up here in just a moment. We want to go ahead and get you caught up, however, on your weather. It's going to be a high of 79 degrees today with 79% humidity. It's currently 8:35 a.m. here in the Metroplex. And it's interesting. I pull up the traffic, and it gives me San Antonio traffic. Anybody want to know San Antonio traffic? I don't.
I don't know that that's going to help us here in the DFW area. I mean, you can give it to us if you'd like, JP, but
no, I'm not going to. So we'll get traffic on the end of the segment, and I'm going to go ahead and let's go ahead and introduce our guest this morning. We are very excited to have Nicole Ortiz. She is the Director of Clinical Services, and we're going to be talking about bipolar disorder today. Nicole Ortiz, good morning, and welcome to JP, Kathy, and the crew.
Good morning. Thank you for having me.
So tell us a little bit about yourself, and what are some of the programs that you are leading?
Well, I'm currently the Director of Clinical Services at Life Healing Center, which is a trauma and addiction rehabilitation center in Santa Fe. I have been here almost a year now, and just loving leading these programs, working with people with acute mental health at the residential treatment level.
Okay, and so Patty or Steve, jump right in.
Thank you, John. Good morning. Nicole, good morning. This is Steve and Dad from the Morgan Foundation here. First, thank you for being on the show. We know that one of the things that you encounter in your practice is you routinely are faced with people with bipolar disorder. Wonder if you could go into that, explain what exactly that is and the different types.
Absolutely. Bipolar disorder is something we see a lot in residential treatment. Just due to its acuity, the symptoms can be really, really hard for people to manage in daily life. It really affects functioning on every level. So a lot of people come into residential treatment to work on healthy coping, how to work around what addiction looks like with the co-occurring with severe anxiety and addiction with bipolar disorder. And I think it's one of the things that we seem to specialize here at Life Healing Centers, working with those folks. So we like to help them get back their daily functioning and back on track with healthy coping and getting back to a healthy life that feels hopeful, manageable.
So
I think one of the trickiest, I'm sorry, go ahead.
No, go ahead, please.
I think one of the things that we see most is working with the folks with Bipolar One Disorder, which really is the deep, heavy depression marked with the manic episodes that can last up to a week. So severe that people need immediate hospital care sometimes. Usually the depressive episodes, they can last even up to 2 weeks to a month. So it really impairs daily functioning.
So could you explain a bit the difference between bipolar 1 and bipolar 2?
Yeah, absolutely. Bipolar 1 is the deep, heavy depression that folks can't seem to get themselves up out of. It's the depression that doesn't allow for people to even to work, to shower, to effectively sort of interact with the family. It's that almost unbearable, unmanageable level of depression, marked by what we consider mania, which is that super elevated, high feeling with lots of energy, the increased activity, feeling jumpy. Those kind of levels of mania lead to the really risky behaviors that can cause people to get into a lot of trouble in those areas. Bipolar 2 is more of a rapid cycling mood disorder. It has less high features. It's not really considered mania. It's more what's considered hypomania, which is a less severe form of mania. So it's more of a rapid cycling in and out of the mood disturbances.
Okay, so it sounds like in your description of bipolar 1, a lot of what you discussed could be your basic definition of depression. What are the differences between a diagnosis of depression versus a diagnosis of bipolar disorder 1?
So that's where we get into the misdiagnosis a lot with severe depression and bipolar 1, which is why bipolar is really tricky and can go unrecognized, for a long period of time until people can get into the doctor and really talk about, I've got this severe depression, I'm not doing well. But then all of a sudden I was like super elated, had all this energy, I got my house clean, I did all this stuff I haven't been able to do, in months. And that's where we start to look at, okay, this sounds more like bipolar. So people don't tend to go into their primary care or their psychiatrist or whoever they're seeing until that severe shift happens. So we tend to think someone just has like major depressive disorder when really what we need to treat them for is bipolar. So until that mania appears, it really does look a lot like major depressive disorder.
Something that I have been understanding as well is that in addition to the common misdiagnosis, because of that probably, that they take longer to seek the treatment because they're seeking treatment for the wrong diagnosis.
Absolutely. And one of the things that's really hard with that, adding on that complication, is the medications are different. And I'm not a doctor of psychiatry, so I'm not really going to speak too much to medications around these things. But with the medication for major depressive, it doesn't treat the bipolar and can actually lead to some disturbing features in bipolar disorder. So we tend to treat people for the major depression until the manic episode happens and the shift happens, and then they say, like, this really, then the mood tracking really shows up differently. I'm no longer in this depressive state. I'm really up. I'm really high. I'm having all this energy. I have insomnia. I haven't slept in a week, and that's where some of the psychosis can present itself.
And sometimes I understand that people do not self-identify their mania as problematic. So that can take an even longer period of time because when they are seeking counseling, they're not identifying it and not giving a history of some of those episodes. Could you speak to that for a bit?
Yeah, absolutely. And I think what some folks are experiencing around the mania is it's the first high energy moment they've had in sometimes months. So it feels good. It's right. Tricky. It really shows up as, I really feel good now. Maybe I don't need to be treated. Like this feels great. I'm getting a lot done. I'm spending a lot of time out of my house. And then when it starts to move into becoming problematic, where the risky behaviors are starting to show up, the high risk behaviors, the grandiosity, acting out with peers, with loved ones, not sleeping, and moving into behaviors that are really problematic around that, with the substance use, can start to show itself in this place.
Well, Nicole, when you say acting out, I know that's not like your typical what you would think of acting out. What would that be? How would you describe that?
I would describe it as unusual behaviors that someone wouldn't typically have, like high risk sexual activity or overspending, buying really expensive things people wouldn't normally buy, shopping sprees. Some gambling can come into this acting out, being up for hours and hours, and becoming agitated, irritated, not, acting well with the family or with friends. Spending lots of money and recklessness is what we talk about when we look at acting out.
Okay.
So sometimes it's going to be incumbent upon family, loved ones, friends to identify these problems if the person themselves isn't recognizing it. Are they very successful at hiding these behaviors? And if so, what should people be looking for?
Well, I think it's some of the behavior I think can be hidden when we're doing things outside the home. But the behavior tends to be so risky, it's kind of one of those things that doesn't really lend itself to not being obvious. Okay. So it's, driving at high rates of speed, going on huge shopping sprees, like things that are out of the typical normal behavior. not just having a lot of energy and being in a good mood, but really taking it to the extreme.
So when the behavior gets to be that high risk, what does a family member do to be sure that they're helping the person get help, but not doing more than they should or doing something to add to the risky behavior?
I think just having really honest conversations with the people that we care about, talking about the behaviors, recognizing the patterns that seem out of the norm, and being open to discussing what treatment needs to look like.
Ms. Ortiz, one of the things that has really struck me as you've talked today is a lot of the activities or actions that you have described can also in some ways be described as a person being eccentric or out of the mainstream or not, quote, normal as what society defines. How do practitioners come up with that dividing line between a condition that needs to be treated versus a person who might have certain just eccentricities?
I think eccentricities look more like quirky personality traits, something that would be not considered risky perhaps, but more just like an interesting sort of presentation, where I think bipolar mania really looks like extreme behavior.
Okay, now, how common are the bipolar disorders 1 and 2? They're about, for instance, there are about 325 million people in the United States right now. We know, for instance, in eating disorders, there will be approximately 30 million who will suffer from some type of eating disorder in their life. So how prevalent are bipolar disorders in society today?
Well, according to the National Institute of Mental Health, about 3% of American adults have bipolar disorder. About 4.5% of American adults reporting they've had some sort of a symptom around mania at some point in their lives. So to sort of look at how that affects the co-occurring disorders like anxiety or eating disorders like you just mentioned, it's a mood disorder that can really manifest in these other areas. So one of the feelings that comes with bipolar mania or bipolar depression is that feeling of being out of control, not being able to control moods, feeling kind of one extreme and then the other, really high or really low. And bringing in the eating disorder conversation, that's a way to sort of control a part of the life. When everything feels extremely out of control, in other areas, people can control the way that they eat. They control how much they take in or how much they purge out, and it becomes a way of coping. An unhealthy way of coping we look at in the co-occurring with substance use and eating disorders.
So one issue we have not addressed yet, and we only have about 2.5 before break, is addictions. How often do we see addictions occurring with bipolar disorder?
Well, unfortunately, we see 30 to 50% of those suffering with bipolar disorder will develop a co-occurring substance use disorder. So it's pretty high.
So when that does occur, do most practitioners try to address the addiction aspect first or the bipolar disorder issues, or are they so linked that you have to address both at the same time?
Well, I think one of the things we look at in addiction treatment is that's the main qualifier that will bring somebody into treatment a lot of the times. They go into treatment because of substance use really makes life not functioning the way that it needs to. So that's a lot of the way that we bring people in for bipolar disorder treatment is we start to look at the substance use, and then we look at what's underneath the substance use. What are people numbing from? What's happening in their lives? And that's where we start to look at these patterns and discover things like the bipolar disorder.
Do you notice commonality between bipolar and the various addictions? For example, alcohol versus other substance abuse and bipolarity? Or does each addiction take a different form?
there's a really high prevalence of alcohol use with bipolar disorder that we notice in treatment. I think that one of the things with alcohol use disorders is that alcohol is a substance that's legal. So it's easier to acquire, it's easier to use, it's more socially acceptable.
Very good. Yeah.
All right, let's go ahead and run off to break. Of course, don't forget, if you're on our social media at JP, Kathy, and the crew, you can continue the conversation as we will continue to ask questions of Miss Ortiz and go through her expertise. So you can always tune in again at Facebook at JP, Kathy, and the crew. If you have any questions, that's a good place to pop on as well. I know one of the things that we'll talk about at the break is it seems like the mental health industry is so hard to be able to get a fix and not have to try different medications at different times. We'll be right back after these messages. All right, Miss Ortiz, you still there with me?
I am.
Awesome. And Facebook can hear you, so we like to continue the conversation.
So one of the big questions that's coming out is that it's very frustrating to get a good mental health diagnosis. And it seems like it's a try this, try that. If that doesn't work, try this, try that, doesn't work. Can you kind of give some background on that and sometimes how it just may be that way?
Well, I think one of the tricky parts of dealing with any of the mood disorders is it seems to be this sort of population has a hard time sort of wanting to be in that trial and error phase of medications. And medications we're seeing with the psychotherapy modalities are really have the highest success rates in treating bipolar disorder. But there is a real stigma attached to being on long-term medications. We feel like, moving in, and feel like this country is moving in a direction of wanting to be more holistic and look at the body-mind connection, where with certain disorders, there is the brain chemistry piece that really needs to be addressed, and medications really are what helps along with the psychotherapy. It's kind of a twofold. I really like to work with folks in relieving some of the trauma symptoms, helping people to reconciliate some of what feels like the internal incongruencies, how my outside affect doesn't really match how I'm feeling on the inside. And that, looking at that sort of acceptance piece brings a lot of people, I feel, into more of I can look at myself wholly inside out and look at all of the pieces, and how can that all come together to heal the self internally. That sort of brings the presentation externally into a more positive place.
Nicole, so has research that has been done on this disease indicated whether there's a genetic link or biological background or basis to this disease?
There is a genetic link. Some disorders do run in families, but what we're noticing with bipolar disorder is that there tends to be a chemical imbalance, a genetic predisposition, that a triggering traumatic event can sort of trip that switch and bring you into that symptomology. So you could have this sort of lying dormant, if you will, in this predisposition and never have it surface unless something really happens that is a high stressor, is a traumatic event.
I know that trauma treatment is something that you have a lot of specialization in. Maybe when we come back from the break here, we could go into trauma and if there's a particular type of trauma that presents itself more frequently when we return.
Also, we want to address what people can do to seek help or what
give
resources.
People hope.
Absolutely.
Yeah, we want to make sure we give people hope.
Yep.
Perfect.
And we will not have time to address stigma or all that. And
God, this is one of those topics you need. You need an entire month to cover it.
And don't we say that every Tuesday?
I know we say that.
I know, it's so bad.
It is. You know, we've got several, like we've got, well, we're about to come back on air.
Here we go.
Later.
morning. Welcome back to 1160 a.m. KBDT News Talk Sports. Today is Tuesday. It is currently 8:54 on your dial. And we want to welcome you to JP, Kathy, and the crew, the Mental Health Moment, brought to you by Acadia Health. Also want to thank Morgan Foundation and Something for Kelly Foundation as well. We're going to go ahead and give you your traffic very quickly as we get ready to send you off into the Metroplex, and we finally are out of San Antonio and back into Dallas. And I'm going to tell you, you would have rather been in San Antonio.
Oh, man.
Because Dallas is looking miserable. The Dallas North Tollway, of course, is backed up all the way from Prosper to downtown Dallas. There is an accident right at the Dallas North Tollway South at LBJ, right lane blocked at Spring Valley. Your commute's going to kick you back all the way to Keller Springs Drive to Inwood Road, about 15 miles an hour. US 75 is backed up on both the north and south side. This is going to be between Park Lane and I-35 South. You're going about 18 miles an hour. LBJ in Garland, backed up way bad. Skillman Street all the way to Northwest Highway. Your commute 14 miles an hour. Another accident now reporting in the Dallas area on 183 West at Highway 114. The backup is all the way to the Mixmaster. You're looking at from about Loop 12 to John Carpenter Freeway, 21 miles per hour. Another accident reporting on 114 John Carpenter Freeway West. This accident is blocking the exit ramp east of DFW Airport West at Bush. And so the backup goes from Texas 161 all the way to John Carpenter Freeway. Your commute is about 12 miles an hour. Let's head down into the Fort Worth area. There is an accident reporting on I-20 West, right lane blocked at New York Avenue. Your commute is about roughly about 16 miles an hour, all the way from the ramp at 360 North. So do be careful there going into downtown Fort Worth. Also, accident reporting on I-30 West at Country Club Lane, and your backup starts at the ramp at I-820 and carries you all the way through to Bridge Street and Bridgewood Drive, and your commute's about 20 miles an hour. There is also on 114 Northwest Parkway East, all the way from Trophy Lake Drive to North Whitechapel Boulevard. Your commute is roughly about 17 miles an hour. And I mean, it is looking real bad out there traffic-wise, so do take your patience, a great cup of coffee, and JP, Kathy, and the crew with you where you go. All right, we're back to the Mental Health Moment. We're going to kick it back to you, Steve and Patty, as we are talking with the clinical director and about bipolar disorder. Go ahead, Steve.
Well, actually, we're going to change it up just a minute here. Over the break, we thought we were going to start with trauma, but, the Dallas traffic just gave us our own trauma experience.
Good transition.
So we always like to have hope in every segment.
Yes.
And so, we are so
Nicole.
Often having
Nicole.
having doctors with. Anyway, stick to hope. Let's start with that, Nicole.
I'm close, but I'm not there yet. But close. Looking at, hope, there's always hope. There's so many wonderful treatment modalities out there to treat bipolar disorder. It's more recognized and more spoken about nowadays. It's something that used to be really stigmatized in movies, and now people are sort of recognizing it. And I'm loving what we're doing with Acadia Healthcare and Life Healing Center, because we've got these amazing treatment placement specialists that you can get online and you can research, and they can find you the perfect treatment in your area for whatever it is that you need to look at, especially bipolar disorder. So with the aid of really good, medications to sort of balance the mood and the chemistry, and really great, proven, effective treatment modalities like cognitive behavioral therapies, looking at where the cognitive distortions and the messages are kind of not where they need to be in the mind. There's so much we can do to treat bipolar disorder. It's definitely something that's spoken about and looked at nowadays, and I think that there's always hope to feel better and to move forward and just make your life work how you need it to work. I love that people like Michael Phelps and Nick Jonas, they're doing these commercials advocating for mental health care and bringing it into conversation.
Well, and there are people who are elected officials. There are famous, actors, actresses. There are people who are extremely, business owners who are extremely successful in their line of work who have bipolar. It's just a matter of going through the process of getting the right medication and the right treatment.
Exactly.
Nicole, Nicole, thank you so much for joining us. We sure appreciate that. And Cannot thank you enough for the information. Would definitely love to get you back on and continue the conversation about bipolar disorder. Steve, did you have some waning words there?
Other than for help here in Texas, you can go to herefortexas.com and type in bipolar disorder, and experts will come up. And I'm sure Nicole can give us your contact information. We'll put it online. And thank you for appearing with us.
Yes, good session
Thank
this
you
morning.
so much for having me.
Thank
All right,
you,
now Nicole, don't hang up. Stay on the line. We continue the conversation for just a few more minutes. And again, if you're out there in traffic, do be careful. You're playing dangerously. Coffee and patience. We'll
Have
see you
a
tomorrow.
blessed day.
All right, and the conversation can continue.
Nicole, yeah, thank you so
And
much.
we've got a bunch of questions that have come in. Nicole, is there any way you can go to the JP? We're off the air now, but we're still on our Facebook Live audience. And we have somebody who comes in and adapts the mental health moment to take out this 30-minute segment. Is there any way you can go on to our JP, Kathy, and the Crew Facebook Live feed from today? We've got several questions about medication. And here's a question. Can it be triggered by divorce?
I actually am at work, so I don't have access to Facebook. I'm sorry. I can give you my email, and I can answer questions that way.
Okay.
If that's helpful. But at work, we don't have access to social
Gotcha.
media,
Okay.
unfortunately.
Even if it's for the point of education.
but yeah, absolutely. You know, we see people. The average age onset of bipolar is around 25. So we see the link between traumatic events like job loss, divorce, death of a loved one. Any really profound traumatic event can trigger episodes. So we see these kind of things really linking to the major depressive states that come with the traumatic events, and that moving into, with the predisposition and the genetic link, moving into things surfacing like bipolar depression.
Then if you've got a child who's been diagnosed or is being treated for bipolar, yeah, well, but it's, a lot of times I know they won't necessarily give somebody under the age of 18 a true bipolar diagnosis, but if they're being treated for the symptoms of bipolar, I mean, can that start as early as 3 years old? And how would you recommend parents go about helping somebody who's underage versus somebody who's in their 20s or 40s or 50s and has a bipolar break?
I think that always staying honest in the conversation with your provider, allowing them to spend time, evaluating your children and really getting a look at what's happening. People I think dismiss a lot of behavior as, oh, that's really aggressive behavior or really the risky acting out behavior. That's just not normal behavior.
Right.
So that's where the red flags start to come in. Do we see a child who's easily agitated, who is quick to self-deprecate and go into those deep kind of depressive moods? That's just not typical childhood behavior. So keeping an eye on these things, tracking them, and bringing them to your providers and allowing them to really do an assessment and evaluate can sort of bring that into the conversation a lot earlier. We do see a lot of schools nowadays really bumping up their mental health programs, working with teachers a lot of the times about right?
Yeah.
It's about time.
Yes.
A lot of teachers are now the first line of defense, right? So they're the ones spending the most time with the children. So having the conversation with the child's teachers and really kind of saying that this is not, this is out of the norm. Kids are now showing the symptoms of doing poorly in school all of a sudden, not being social any longer, having these sort of bouts of irritability and not getting along with their classmates where before everything was fine. So it's really keeping an eye and having open, honest conversations that I think will bring it into more awareness.
You brought up something that I think is real important, and I don't want to pass over that. You mentioned something about tracking. It's real critical to understand the history of the patient so that when you do go to the healthcare provider, you're able to say, this is when it started, this is how long it lasted, this is how frequently it occurs, this is how severe that it was. And the patient themselves is not always aware to identify. So if a parent is still has a child at home, that would be very helpful.
Absolutely. Absolutely. And that goes for anybody in partnership. A lot of times we don't, what we say, we can't see the forest for the trees, right? You can't really notice these episodes when you're in them. It's like you're kind of surrounded by it so much it doesn't really come into the patient's field of vision. But the people outside looking in can say, you know what, there's something going on. And it doesn't feel like your, regular self, like what's going on, let's talk about it. And having a second set of eyes can just be so completely helpful.
And I think the other operative term is out of the norm. So that's the whole point. If somebody is acting substantially different than they normally do, that sort of is another distinction between somebody who has an eccentricity about them and somebody who might have an illness.
Absolutely. And out of the norm for their behavior, right? Not comparing behavior to other people, because there are people who are just eccentric, but is the behavior out of the norm for that person?
Right. Yeah.
Right. That's what to keep an eye on.
Okay, Nicole.
Great information, Nicole. Thank you. And as we learn more and more about the bipolar brain, I know some of the frustrations on Facebook. It's saying that they're saying that it takes a long time, and years can pass before you can get the real help you need. But eventually, you can get the right combination of medication. You can get the right systems in place. It's just, I think with bipolar, I think it's constantly a balancing act. And as long as you're in the life of that loved one, your family member, or whoever that is, that's part of your reality.
Absolutely. And I can't stress enough how important it is for the loved ones to get the support they need as well. Because being, in partnership with somebody who is dealing with a serious mental illness is hard. It's not impossible. It's not something that people should dread or fear, but also understand it is a lot of support, and it is unusual, and it is something that we're not raised to typically deal with or look at. So there are a lot of great support systems out there for support people with bipolar depression
I'm
as well.
so glad you said that, because it can be just as hard to be the person dealing with the person and trying to help the person with bipolar as it can be to be the caretaker of that person or somebody who's a loved one.
Absolutely.
I'm glad you said that.
Traumatic in itself.
Right.
So we want to take just a couple of seconds and say that next week we have Dr. Michael Luter on, and he is a medical doctor as well as a research scientist, and he is very proficient in the field of eating disorders. And we thought that as we're heading into the holiday seasons, sometimes people get permission to overeat tremendous amounts. Sometimes it's a trigger for not eating at all. So stay tuned on Tuesday, and we'll talk about patient support as well as family support with holidays and stress.
Fantastic. Thank you. Well, Nicole, thank you so much. We appreciate you. Have a great Thanksgiving.
Thank you so much, everyone. It was really fun. I super appreciate it.
Thank you, Nicole.
Thank you.
Have a good day.
Take care. Bye-bye.
All right, JP, are you still on? JP? Hello, he must have hung up. Okay. Do y'all have anything else y'all want to say to Facebook for the mental health moment?
Go Horns beat Baylor this weekend.
Oh my gosh. Did I say for the mental health moment? This is not the sports segment.
Well, since we're going to probably lose, I'm going to have a meltdown, but that's okay.
I think that's it then.
Okay, all right.
I think we're good, Kathy.
All right, love y'all. Have a blessed day.
Bye, guys.
With the concussion, I'm still being told do a partial week, so I will be back in on Thursday. I think JP's going to have a guest co-host in studio tomorrow. So everybody have a wonderful rest of the day. Have a great Wednesday, and then I'll see y'all on Thursday for Money in the Bank with Frank, live from Wall Street. Okay, love y'all. Mwah. Have a blessed day. And in live video. See y'all. Mwah.